I'm looking forward to that. I went to my first Common Knowledge Edinburgh meeting 2 weeks ago. Simon Milne was talking, and I was very impressed not only by Simon's talk, but by the liveliness of the question and answer session. So I'm looking forward to that, although with a little touch of anxiety and trepidation as well. So I won't say more about my background, but this is the ground I'm going to be covering over the next 30 to 40 minutes. Firstly, what is public health? Because in my experience, public health is the least understood specialty. So I'll just canter you through what public health does. And then I'm going to address the question, were we prepared for the pandemic? Perhaps people could put their right hand up if they've heard in the media at any point that we weren't prepared for the pandemic and we didn't have a plan for a pandemic. Anyone heard that in the media? Yeah, quite a few. I've certainly heard it several times, so I'm going to address that very important question. And then the meat of the session will be, so how did we do? What was the response like? And I'll try to give you a fairly standard public health assessment of how we responded, at least standard before March 2020. And then at the end, I'll be trying to draw out some key lessons, some high-level lessons for what we should do in the future. So, the key thing about public health is that it takes a population focus. So we very rarely treat individual patients, we look at the whole population. So the Lothian Public Health Department will look at the whole of the population of Lothian and consider what are their needs, what are their health problems, what do we need to do about them. And the three branches of public health, health improvement or disease prevention, that used to be called health education or health promotion. So how do we keep people healthy? The second is service improvement. So that works with clinicians and NHS management to refine the health services we provide. So how many cataract replacements do we need in Lothian per annum? How many hip replacements do we need to provide? When do we prescribe statins, when do we not, and for who? That sort of thing. And it uses needs assessment, which is trying to quantify the needs, and evidence-based medicine, which is looking at the evidence for effectiveness. So both of those are important, the qualitative and the quantitative. Health protection is the subject really of today's meeting, so that's the part of the specialty which manages outbreaks of infectious diseases in the community. And they also are involved in pandemic planning. So that's a key function. Where do you find the public health departments? Well, every NHS board in Scotland has one. Lothian has one. Borders, where I come from, has one. And the same within elsewhere in the UK, within the respective structures. They all have local public health departments. You find them also in national organisations, Public Health Scotland, UK Health Security Agency, and in America, CDC. So every country has a national public health agency of some sort. And of course, the WHO, in effect, is a public health global agency. You also find them in most major universities. So in Scotland, we have public health academic departments in Edinburgh, Glasgow, Dundee, and Aberdeen. So quite large departments. So that's what public health is. Were we prepared for a pandemic? The second question. Well, this is some of the recent guidance. Firstly, the WHO produced a document in 2009 about this, giving guidance to all countries about how best to prepare for pandemics. The UK produced what I think is a very good document, UK strategy, in 2011, which I'll quote a little from. Additional guidance in 2013, and these sorts of documents were used by each local public health department working with its local partners, mainly the councils, the local council in the area, to produce pandemic plans, and they were reviewed every year and updated every year. So quite a lot of work went on to prepare for a pandemic, and clearly the pandemic that people had in mind was an influenza pandemic, But for example, the 2011 UK strategy explicitly said these plans can be used and adapted for other respiratory viral pandemics. It actually gave as an example SARS-CoV-1, the first SARS virus. So it wasn't just for flu. So with these plans could and should have been used. The last point there, an organisation based at the Johns Hopkins University in the USA assess the readiness of countries across the world to respond to a pandemic and other potential emergencies. And in 2019, late 2019, they completed their world assessment of pandemic preparedness, and the USA came first out of about 190 odd countries, and the UK was second. So I think to say we weren't prepared is not quite accurate. Right. So these are some quotes from the UK strategy of 2011. It will not be possible to halt the spread of a new pandemic influenza virus. And the same applies to SARS-CoV-2. You cannot stop respiratory viruses spreading, but we've perhaps tried in this last pandemic. The second one on the right, during a pandemic, the government will encourage those who are well to carry on with their normal daily lives as long as possible. We didn't quite do that this time. And then, last but not least, the response will continue to be evidence-based, based on best practice, based on ethical principles. So that's the guidance that was being given at the UK level. And this guidance was used to produce local pandemic plans. Third question, how did we do? Well, I'm going to address this by looking at 4 key public health principles. The first, ensuring accurate data on health and disease. If we don't have that, we don't know what is going on in the community, and therefore we don't know how best to respond to it. 2, assessing the evidence for effectiveness of interventions and their costs and their benefits. Thirdly, broad focus on the whole population and all health problems, because even if we have a pandemic going on, people still get heart attacks, people still fall over and get broken hips, etc. So we have to still respond to all of these other problems, otherwise lives will be lost. So we cannot afford to focus only on one problem. And then last but not least, providing accurate information to the public and avoiding unnecessary alarm. So, yes, I mean, well laugh. So these were standard public health principles before March 2020, and principles which were within the pandemic plans. So this is looking at the first principle on accurate data. And on the left we have what was in the plan, the pre-pandemic planning approach, and on the right we have the COVID pandemic response. So the first thing is confirmed case definition. Now this may sound a bit nerdy, but it is crucially important. And when there's an outbreak in a community, the Public Health Department call an outbreak control team meeting, and at that first meeting, very high on the agenda, is defining and agreeing what a possible, probable and confirmed case is. If you don't have clear definitions, when you have your data, you can't interpret the data, you don't know what is going on. And invariably the confirmed case definition was someone with relevant symptoms of the disease in question, plus a positive test that identifies the causative organism as being present in that individual. Always the two together, someone with a disease with symptoms and then a positive test. In the COVID pandemic, and this is the first time I've come across this in my career, a positive test alone was sufficient. You didn't need a person with symptoms, you didn't need any disease, just a positive test. Not only that, but we set this PCR test at a level where it was far too sensitive, 40 cycles, above 25 cycles, it's very likely that the person, whatever you're picking up, it won't be an infectious viral particle. With this test, if you run it at 40 cycles, it can pick up 1 or 2 strands of viral RNA, not a whole virus particle. You don't even need a whole virus particle. It's so sensitive. So running the test at that degree of sensitivity will generate lots of false positives. So very different approach to a case definition. And that change will have inflated hugely the number of cases that we were counting. So the numbers of cases you saw being presented every night on your TV were inflated. They weren't an accurate representation of the real number of cases out in the community. We went one step further and we introduced widespread testing in the community when that wasn't recommended in the plans. And these tests weren't designed for widespread community testing. And when you do that, particularly if you don't need symptoms, you just need a positive test, you will pick up lots of false positives. And I've shown here, I've given you a calculation of 2 million tests per week. In fact, at the peak, we were doing about 3.2 million tests every week. So 2 million every week, with a very conservative estimate of a 1% false positive rate, gives you 20,000 false positives being generated every week. And all of those people had to isolate for a week and even up to 2 weeks at one point in the pandemic. So you can imagine the impact of that on services and businesses. On top of that, you've got the real cases who are isolating, and then you've got the usual people who are off work because they have a sore back or angina or whatever else. So not surprising, the NHS had difficulty running the service. So 3 rows down, hospital admissions from viral disease, caused by viral disease or flu, is how we would usually count hospital admissions caused by a disease. In the pandemic, we didn't do that. We counted admissions from or with COVID or a positive PCR. So someone who fell over, broke their hip, went into hospital. Everyone, when they went in, were tested, of course, PCR test. If they were positive, they were counted as a COVID admission, hospital admission, even though what took them in was the fractured femur. So again, that would have inflated the number of apparently COVID hospital admissions. And then last but not least, deaths. Usually they're counted if the viral disease is the underlying cause. But in the pandemic, death within 28 days of a positive PCR was enough. So the person who broke their hip perhaps developed a DVT, a thrombosis in the leg, and then a pulmonary embolus, and eventually died from that. Because they had the positive PCR test, and then they died within 20 days of that test, they were a COVID death. But nothing to do with COVID whatsoever. So that would inflate the number of COVID deaths as well. And when the doctor completed the death certificate, there's 4 positions for causes of death. COVID being mentioned in any of the positions, not just the underlying cause position, resulted in that death being counted as a COVID death too. So we have inflation of deaths, hospital admissions and cases. And I think this was a large part of why we potentially overreacted to the pandemic, because we were counting far more cases, hospitalizations and deaths. And that drove alarm and fear. So in this one, I'm looking at measures to reduce transmission of a virus. So on the left-hand side, what we traditionally did was to recommend people with symptoms of the disease should isolate. They're producing lots of viral particles and they're coughing and sneezing and dispersing them very efficiently to others around them. So we recommended isolation to minimize spread. We felt that contact tracing was ineffective, except in the very early phase, so we didn't use widespread contact tracing. And mask wearing was only recommended for healthcare staff, not thought to be effective. What did we do in the pandemic, the COVID pandemic? We isolated those with a positive test, real cases, and all of the 20,000 false positives. We also isolated their close contacts. So each person may have had 2 or 3 close contacts. So the 20,000 becomes 60,000 or 80,000 every week. And we also developed this contact tracing service. I can't remember in Scotland and in England what it was called, but it cost £30 billion to develop and run this contact tracing service. We did that for most of the pandemic, but not thought to be effective. Very little evidence that it does much. And we also, of course, introduced widespread community mask wearing and mask mandates. 4th row down, in the pandemic plans, because children are well known to be super spreaders, they pass on the flu virus very efficiently. We've developed a nasal spray vaccine for them, and that gives them mucosal immunity and it stops them transmitting it to others. So that's what we use for all primary school children get this, and now secondary school children. And very early in the pandemic, occasionally, we'd recommend school closures, but only early in the pandemic. And we also recommended focused protection of those who are vulnerable with comorbidities or the elderly. In the COVID pandemic, we had regular and sustained school closures, despite not having any evidence that children were super spreaders of COVID, of SARS-CoV-2. And very poor evidence that school closures actually achieve very much, apart from destroying children's education. And then on the far right, the bottom right, we of course locked down businesses, healthcare, at least the routine healthcare, and individuals. We locked down individuals in their own home, and we didn't have a robust cost-benefit analysis of any of that either. So there were the measures to reduce transmission. So this was a very important document that the UK HSA brought out just in September of this year. And it looked at a thorough review of the evidence from the UK, which had been collected over the last 3.5 years. And it concluded the body of evidence available on the effectiveness of NPIs, non-pharmaceutical interventions, in the UK provides weak evidence in terms of study design. What a shame we didn't have this at the beginning of the pandemic, you might say. Well, we did. We had a very good Cochrane review, that's a gold standard review of the evidence, which was published in 2011. And then this one from the WHO was produced in the autumn of 2019, just before the pandemic. And it produced very similar conclusions to the UK HSA one. The evidence base on the effectiveness of NPIs in the community setting is limited. Overall quality of evidence is very low. Few randomized controlled trials, the gold standard assessment, and mainly observational studies and computer simulations or modeling. So poor quality evidence for all of these, almost all of these NPIs. But we still introduced them. And this is some of the detail from the WHO review. And we can come back to this in the discussion potentially, but I just wanted to point out the bottom row, the things which were not recommended under any circumstances, even with an extraordinarily severe pandemic. And they were contact tracing, isolation quarantine of contacts, entry-exit screening, which we did and other countries did even more, border closures, which we did for a while and other countries did more, and lockdown of citizens in their own homes wasn't even contemplated. So we introduced a lot of things which weren't recommended under any circumstances. So this is moving on to the evidence principle, looking at measures to protect individuals and treat individuals. And pre-pandemic, planning for flu recommended vaccination of health and social care staff and vulnerable groups, so the elderly groups and those with comorbidities. In the pandemic, of course, we vaccinated most of the population, despite the fact that we didn't have much evidence for effectiveness and safety. And interestingly, we made no comment. Well, Boris Johnson did make a brief comment, and he was shot down about obesity. He commented about his own obesity, and he might not have had such a bad experience with COVID if he'd lost a bit of weight before, and I think that was probably true. So that was a major risk factor, but not mentioned. Nor was vitamin D, and we had fairly good evidence that high dose vitamin D was protective. And that's accumulated since. So there's very good evidence now that high dose vitamin D is protective. So I'll go on to say a little bit more about effectiveness of the vaccine. And firstly, it's not a black or white issue. It's all about degree, about how effective something is or ineffective. And it's about selecting the patients who can benefit most. So on degree, two important issues. One is, which outcome measure do you use? Cases, hospitalizations, or severe disease, or death? Ideally, you want good information on severe disease and death. That's the really important impact of a disease. It matters less if people are picking up an upper respiratory, cold-like illness for a few days and then recovering completely. But severe disease, enough to take you into hospital, or death is very important. The other issue is which risk reduction measure we should use. And ideally we should use both. But the two are absolute and relative risk reduction. And I'll talk you through this data here. The figures here I've taken them from the AZ Oxford COVID trial. And in that trial, which ran in the sort of late spring, early summer of 2020, the control group who didn't have the vaccine, 1.7% of them developed COVID-19. The group who were vaccinated, 0.5% of them developed COVID-19. So a significant reduction in the risk. And you take one from the other, 1.7 minus 0.5 gives you 1.2%. That's the absolute risk reduction measure. Very simple measure. The relative risk reduction is the absolute risk reduction of 1.2 over the original risk, 1.7 in the control group, multiplied by 100 to give you a percentage. That's 70%. And the figure you'll have heard on effectiveness for the AZ vaccine will have been 17%. Pharmaceutical companies like to use the relative risk because it's a nice large figure. It sounds very effective, 70% or 90, 95% for Pfizer. But if you look at the absolute risk reduction, it's far smaller. If you were told your risk reduction from this vaccine is 1.2%, you may not have been quite as keen to take it as 70%. But the pharmaceutical codes of practice say that firms should be using both of these, not just one, but they always quote the relative risk reduction. The other important thing about effectiveness is selecting patients who can benefit most. So this is quite a complicated slide, so I'll talk you through it slowly. But on the left, the column on the left, you have age. Second column from the left, infection fatality rate. So that's of all of those who develop an infection, how many die? And it's 1.5% there. And this data I've taken from an American study by Levin et al., published in December 2020. And this is an important study because December 2020 was just before the rollout of the vaccine program. So this data was available at the beginning of the rollout so that our governments and the advisors to our governments could have used this data to design the rollout program. And 1.5, to give you some sort of feel for what that compares to, a typical flu winter outbreak, epidemic if you like, would give us a mortality rate of about 0.1. So this is considerably higher than that. The Chinese initially told us that mortality from the original Wuhan variant was 3.4%. But this American study found it was 3 times lower, 1.5. Mortality from smallpox is about 30%, 30. From Ebola fever, it is 60. So that gives you a feel for where the 1.5 sits. So the next column, the absolute risk reduction. What I've done here is I've assumed that the 70% reduction observed from the AstraZeneca-Oxford trial applies to mortality. In actual fact, the trial only showed a significant reduction in cases. It didn't show a significant reduction in hospitalizations or severe disease. It didn't show a significant reduction in deaths at all. We have no evidence from the RCT, the AstraZeneca RCT, that mortality was affected. So I've assumed for the purposes of this that it would reduce mortality by 70%, but that's a big assumption. If it did, in the 85-year-old at the bottom line, the very high 15% mortality. In fact, I should have said before going on to column 3, if you look at column 2, the important thing there is that the risk, the 1.5% overall risk, if you look at it by age group, it is very different in different age groups. So a 10-year-old has a risk of 0.002% mortality from COVID-19. 85-year-old 15%, and it gradually goes up and down as you go over the age groups. So well known in December 2020 that the mortality risk from COVID was varied by age, or was age stratified. And that's a very important factor when you come to design a vaccination program. You need to identify who can benefit most from the vaccine. So moving back to the third column, absolute risk reduction. The bottom line, 85 years of age, 15% infection fatality rate. That the risk reduction is 10.5, leaving them with a residual 4.5% risk of COVID. So a substantial reduction if it does reduce mortality risk. The next column on the right, NNV, is the number needed to vaccinate, and that can be easily calculated from the absolute risk reduction. It's simply 100 over the absolute risk reduction. But it's a useful statistic because it tells you, for example, in 10-year-olds, you need to vaccinate 71,000 10-year-olds to avoid one death on balance. But you only have to vaccinate 10 85-year-olds to avoid a death. So if you like, the vaccine is a very good buy the older the person is. The benefit is far greater. The final column calculates the NNV, the number needed to vaccinate to avoid one death, but it does so for a lower IFR of 0.23%. And I've used that because John Ioannidis, the guy who produced this estimate, an American epidemiologist, that estimate is reckoned to be the best available at the time, the most accurate. So the 1.5% from Levin was an overestimate, and there were lots of estimates floating around, and there's quite wide variation. But John Ioannidis, his estimate was reckoned to be the best, so 0.25. And if you adjust the NNV calculation for that, you end up with 500,000 children needing to be vaccinated to avoid one death. And at the other end of the scale, 65. So this sort of data is very important in designing a vaccination program. So in summary, the things that you need to bear in mind here are, firstly, the uncertainty about any effect on mortality. Secondly, that when you look at the benefits, the absolute risk reduction and the NNV, you need to bear in mind that when you give 500,000 children a vaccine, you'll give them some side effects. Some of them will develop side effects. And there's significant side effects like myocarditis, particularly in teenage children. Estimated to be 1 in 3,000 teenagers will get myocarditis, which is quite a serious disease. And we're not yet sure about what the long-term effects of that will be. So if you give 500,000 10-year-olds and almost 100,000 25-year-olds this vaccine, you will get lots of cases of myocarditis. So you might prevent one death, but you might cause a death from myocarditis and certainly give a serious illness to many other children. And that's just one of the side effects. There'll be neurological side effects and thrombotic side effects. And the other thing that you have to bear in mind with all of the vaccine trials is that they all ran for 2 or 3 months only, during which time they assessed the benefits and they assessed the side effects. There's no long-term data or information on long-term side effects. We haven't been observing the effect of the vaccine long enough to know what they are. So there may be all sorts of long-term side effects to come out yet. And of course, young people will live long enough to experience those long-term side effects. An 85-year-old probably will not. So long-term side effects that we know nothing about is very, very important for children. So my conclusions when I looked at this data was that it was unethical to give the vaccine to a healthy person below 60. And I still hold to that view. And many other people do, although you won't hear them on the BBC, that's for sure. Whatever you decide about your vaccine program or any other treatment, what you must always do is to ensure that patients give informed consent, fully informed consent. To do that, what you have to do is to give them accurate information on the benefits and the risks of the drug or the vaccine. And then you have to allow them to make their decision without coercion, without any vaccine mandates, without any need for vaccine certificates or travel restrictions if you don't take the vaccine, that sort of thing. We'll come back to this if we have time in the discussion, but this is the sorts of data I think you would need to give patients for them to be fully informed. And the two blue bar charts at the bottom are the most important ones. And this is an example using statins and the reduction in risk of cardiovascular disease with statins. And on the left, you've got the benefits, the absolute risk reduction by age group. And on the right, you've got the level of side effects. The top one being all of the 4 individual side effects below. So you can compare the benefit on the left with the risks on the right. And this is the sort of data I think patients need to make a truly informed decision about whether they want a treatment or not. But this currently is not provided for any treatment, but it should be, I think. Back to the measures to protect and treat individuals. On the second row there, antivirals, if effective for higher risk groups, that was in the plan. And we did use antivirals in the COVID pandemic after testing. But importantly, what we didn't do was we didn't use other treatments, repurposed drugs, which did have substantial evidence that they were effective. And we didn't either mount randomized controlled trials just to prove whether or not they were effective. So I'm thinking of things like ivermectin, hydroxychloroquine, and the primary care treatment protocols developed in America particularly for treating COVID, early COVID in the community. Involved these sorts of drugs and anti-inflammatories and anticoagulants. And individual clinicians were getting very good results, they said, using these. And Uttar Pradesh in India used them with very good effect. But for some reason, they were actively discouraged by, within UK and the USA and other Western countries. And we can maybe discuss why that happened in the discussion. At the bottom there, symptomatic clinical support, particularly for people going into hospital, ICU, drips, oxygen, ventilation, and importantly antibiotics for secondary bacterial pneumonia. I think we did most of that in this pandemic, though there's some doubt about whether we always gave antibiotics when we should have. So, third principle, broad focus on the whole population and all health problems. I won't go through this, but we could come back to it in the discussion if we need to. Suffice to say that the narrow focus during the pandemic on the left, the NHS largely became a COVID treatment service, and routine treatments, cancer screenings, heart checks, diabetes checks were stopped, and even cancer treatments, some of those were stopped or delayed. So we neglected the broader focus stuff on the right, and many other effects, but it was very clear what was going on there, I think. Fourth principle, providing accurate information to the public and avoiding unnecessary alarm. We've talked about the inaccurate data which inflated cases, hospitalizations and deaths, gave a false impression that this was a lot worse than it really was. We focused on extreme modelling, notably from Neil Ferguson and colleagues from Imperial College, without really discussing the underlying assumptions which were implausible, let's say. And this is an example of policy-based evidence making. I think it was Nelson Fraser who coined this phrase, which I rather like. We misrepresented the effectiveness and harms of non-pharmaceutical interventions. We misrepresented the safety and effectiveness of the vaccines and how the risk and the benefits change as you go down the age bands. So we simply pumped out the mantra safe and effective, and it's far more nuanced than that. And then last but not least, we deliberately heightened fear and alarm to aid compliance, and this was the work of the nudge unit within government and behavioural scientists. So I don't think we did too good on that principle, really. So, bringing that all together, how did we do? Well, in terms of process, I think we abandoned certainly those four key public health principles. And I hope I've demonstrated that. We abandoned accepted codes of informed consent. We did introduce coercive measures. We didn't give accurate information on risks and side effects from the vaccine, and we over-egged the effectiveness. We abandoned fundamental human rights. One of the problems that I've experienced and many people have experienced during the pandemic is the censorship. If you had an alternative view, you were censored, you were attacked and vilified, and this has happened to a lot of people. And people who I'm retired, so I could speak out without being worried too much about my income. But people who were still working in the service, they knew it was a career-limiting step if they spoke out. And some people were disciplined by their organisation, their trust, and some people were referred to the GMC or the GNC for speaking out. So there wasn't freedom of speech, and there wasn't freedom of movement when we were locked down, or freedom of association. So fundamental rights were limited. In terms of outcome, well, Sweden, that didn't introduce lockdown, or certainly a very lockdown-light policy. It wasn't mandated. They stopped mass gatherings, but restaurants and cafes were still open, and businesses were still working. They had a far lower excess mortality, all-cause excess mortality, which is the acid test of how bad a pandemic has been. And I'll show you some data on that shortly. The other outcome that's worth mentioning is that having come through 2020 and 2021 through the pandemic into 22 post-pandemic period and 23, we should be seeing a reduction in the usual level of deaths, because a lot of deaths that would have occurred in 22-23 were brought forward in time, premature deaths because of COVID. So people died early, which meant there weren't then around in 22-23 very elderly, very vulnerable people with lots of comorbidities to die. So normally in a post-pandemic period you see a deficit of deaths, But we aren't seeing that. We're continuing to see an excess mortality, which is not a good sign. So the authorities don't seem interested in discussing or investigating what the causes are, but the suspicions are that it's connected with our response to the pandemic. So if that is the case, that is not a good outcome. And this is the data I've taken from Our World in Data. And what this does is look at all-cause excess mortality above what you would normally expect compared to previous years. And it looks at the deaths from January 2020 through to October 2023, country by country. And it's cumulative, so it just counts, all of the additional deaths over that time. It just goes up and up. And you can see on the left-hand side, the first wave and then the second wave of COVID in all of these countries when excess deaths went up. COVID, particularly the early variants, were serious. It was a serious disease, and it did result in substantial mortality, no doubt about that. But the ongoing excess mortality, those curves continue to go up in 2022 and 2023. They shouldn't. They should have leveled out, or even they should be falling. So there's something else going on there which is unexplained. And then if you look at the right-hand side, you look at the respective countries. Italy is at the top. The second from the top in blue, which you may not be able to see, is the United Kingdom. That's us. So we had an excess mortality of about 3,000 per million population for this period. At the bottom is Norway and then Sweden, so they did far better. And Sweden, particularly, is the one that didn't introduce a heavy lockdown policy. They had, at best, 1,500 excess deaths per million population, half of ours. From the top, going down, Italy, United Kingdom, Spain, Germany, Ireland, France, Sweden, Norway. So they're the ones that I picked out. You can, on World in Data, you can go and look at this and produce your own charts and include the countries you want. Very powerful tool. So we didn't do so well in terms of outcome. Lessons for the future, the last slide, this one. I've kept it at a very high level. Firstly, open debate, no censorship. If we had an open debate within the medical and scientific community, potentially a lot of what went on may have been stopped, because there were a lot of people out there and a lot of very eminent people who were saying this is not a sensible policy, to lock down, to vaccinate the whole population or whatever, wear masks. So that is very important. If we're to avoid these same mistakes, we have to maintain an open debate, freedom of speech. We have to adhere to the various international codes on fully informed consent, which we're signed up to, but we abandoned, and most other Western countries did. We have to get back to respecting those and implementing those. And then last but not least, we need to maintain sovereignty and democratic accountability. Now, two things by that. Firstly, because the government instituted emergency powers in both the UK and Scotland, Parliament was bypassed. So Parliament didn't have the opportunity to challenge as it should have done. And there were some MPs who would have challenged and questioned whether these policies were sensible, but it was largely neutered because of the emergency powers. That is not sensible. We need, as well as open debate in the medical and scientific community, we need open debate in our Parliament and in society. The other thing that's important is that the WHO are currently amending their treaty between countries and the WHO and the international health regulations, and they're wanting to amend them so that it reduces individual country sovereignty. So the WHO, if our country agrees to these changes, it will mean that the Director General of the WHO can declare a pandemic. He can tell our government what they should do about it, whether he wants us all to be locked down or to have vaccines or treatments. He and the WHO decide, and our government unless they break this what would be an international law then if we sign up to it, they are obliged to do that. So they could introduce vaccine mandates for everyone, and they could lock us down again. So this treaty and the international health regulation amendments are very important. An awful idea. We need to retain flexibility to respond, and we need to decide, what happens to our population, and then, or our politicians and advisors do, and then they're accountable to us through the ballot box. WHO are unaccountable. The Director General is not elected by any population. Thank you very much.